Well, good afternoon and welcome to Evergreen Talks. I'm your host, Brian Prowitz with BP Media Solutions. And each month, Evergreen is going to do this live Facebook event, a talk with the doc, if you will. And today we have with us the man himself, Dr. Timothy Powell, the CEO of Evergreen Family Medicine. Let me share just a little bit about Dr. Powell. Let's make sure we bring him into the screen so he can blush as we brag about him a little bit. Dr. Powell graduated from the Oregon State School of Pharmacy in 1973 and attended Oregon Health Sciences University for medical school training. And then he completed 3 years at the UCLA Family Medicine residency program in San Bernardino, California, and began his medical practice in Roseburg in 1980. Dr. Powell has been chief of staff at both Douglas Community Hospital and Mercy Medical Center, and he currently serves on the Mercy Hospital Board. Dr. Powell was one of the founders of Evergreen Family Medicine, where he works as the group's CEO. Dr. Powell and his wife, Kathy, have three children and 7 grandchildren. So let me turn the time over to Dr. Powell as he presents today's topic, an evolving model of family medicine. Dr. Powell, the floor is yours.
Thank you, Brian, and good afternoon to Douglas County. I am so pleased to be restarting Evergreen Talk. This has been our community town hall. We were previously doing these in person. COVID closed that door, but then COVID opened another door by providing virtual platforms. There's a power of presence, of being able to look into faces that I'm going to miss, but there's also something to be said for the convenience, the privacy that this forum allows. So I do thank you each for joining us. This will be the structure then for these events going forward. They are going to occur once a month. It will be the second Thursday from 4 to 5, each month a different provider, each month a different subject, of course. The format will be 30 to 40 minutes of presentation and then questions from you folks. I would encourage you to let us know if there are topics you'd like us to address. Today, I'm going to talk about a model of family medicine for the 21st century. I'm a family physician. I practiced in Roseburg for 40 years. So much has changed in that time for both you and me. Next is a photo that illustrates some of that change. This is what I looked like in 1980 when I arrived in Roseburg. This is my son, Matthew. I'm the taller one. Matthew is now an attorney in Roseburg. His wife, Dr. Mary Powell, practices OBGYN, and she works with us at Evergreen Family Medicine. My practice looks so much different in 1980. I had 2 employees. I had a front office receptionist and a nurse. It's very personal, very simple. You called, you talked to a familiar voice, you came in, you saw me. When you went to the hospital, I went over there and saw you. It was inexpensive. Office visits ranged from $15 to $23. The $23 charge was for a physical. Our total obstetrical care package was around $200. This included the prenatal care, the actual delivery of the baby, the nursery care of the baby, and the first visit back for both mom and baby. It worked. Folks, that time is gone and it's not going to return. Let me explain why. We like to imagine we chart our own course in life. We control what's next. If we learned anything this past year dealing with COVID, it was how quickly what we assume is normal can change, how external forces can impact choices. That's just how change works. Sometimes it's good, sometimes not so good, but reality doesn't ask our permission. Looking back, there was some external forces and they weren't chosen. They weren't chosen by myself or my patients, but it shaped both of our experience. The next slide lists some of those forces. Now, these aren't the only forces. There were many forces. Life is complex, but these are 4 major ones that I'm going to speak to briefly about how they shaped my experience in medicine and yours. And I want you to watch in each sector how it has both good and bad influences. Our next slide begins with technology. When most people think of change, technology comes to mind, and with good reason. When I started, CT scans were new. MRIs had not yet been developed. Many of the drugs we use today did not exist. Prozac, which is the new generation of antidepressant medications, was introduced in 1986. Lantus, which is the first truly long-acting basal insulin, was approved by the FDA in 2000. A lot of the procedures that you all take for granted today, coronary artery stenting, laparoscopic surgery, had not yet been developed. The internet, 1995, online dial-up. I wonder how many of you remember that. It was 1998 that Google came on the scene, and the first iPhone in 2007. Now, possibly for some of you, that seems a long time ago. I can tell you for me, it doesn't. But can you imagine life without these now? Can you see how quickly and how powerfully what we view as normal changes? And with an increase in what was possible, expectations changed. The next force of change arose out of this very technology. In 2003, Medicare required claims to be submitted electronically. The medical office must bill. Now, previously, what we had done is given the patient what they needed to bill. They took one slip of paper that we gave them, stapled it to their claim form, and mailed it in. It was a bit of work, but it did tie the relationship where it belonged between the patient and their insurance. Now that relationship was between the medical office and insurance. Now, at first, patients loved this, but it did not bode well for them. And this is why. First, there was a disconnect from the transparency of cost. If I billed $18 and the patient went to the front and the receptionist said that'll be $18, and it just didn't seem right, there was an immediate connection to the value of the service that he had just received. Now with the billing to the insurance company, oftentimes that is utterly lost or so confused in the billing process it is hard to unwind and understand. Secondly, there was an extension of the payer, and it could be government or it could be insurance, into office practice. It was needed, you see, to monitor for quality, to review office notes to make sure the billing was correct, maybe to do prior authorizations for medications, referrals, or to approve imaging. Suddenly, a chart, which was previously private, became much less so. Currently, Medicare and Oregon Health Plan are saying, we're going to value-based payments, but they define value. And oftentimes what's important to the government is not necessarily what's important to my patients. Insurances want quality care, but sometimes there's a disconnect between what is truly quality and our ability to measure it. Now, none of these were bad things. None of them were unreasonable, but can you see how the relationship dynamic began to change? Who is the doctor working for? Our next force for change involved a different type of insurance. Medical liability stressors influence physician choices, which in turn limit patient choices and cost. In the early 1990s, most family physicians stopped delivering babies. I was one of those. The cost of insurance became unaffordable. I had no bad outcomes, but still my rates were skyrocketing. I loved obstetrics. I was delivering 30, 40 babies a year. I just didn't have the volume to pay for liability insurance. Now, the result to the patient was that the cost for that care began to rise dramatically. But then most of that expense was directed to the insurance payer, wasn't it? Next, we visit our fourth and our final force for change. When environmental restrictions disrupted the timber industry, it also impacted the fabric of our rural community. timber and farming is such a part of our culture, and with the lack of other sustainable industries that offered family wage jobs and good health insurance, and without the discipline and the self-respect that came with earning your own way, there was a human price that we paid. Now, in fairness, there was a lot of factors that have affected social changes that have occurred. What is unquestionably true is that change occurred, that a rural-urban divide exists. And the results that I have seen in my practice include social disarray. The family unit has been redefined, and not in a healthy way. Increased drug and alcohol use, mental health problems, and homelessness. The next slide speaks especially to homelessness. National research shows that when housing cost is greater than 30% of income, folks are very vulnerable to homelessness. 30% of income. Any crisis, an unexpected car repair or whatever, can place these households at risk of homelessness. In Roseburg, about 3,500 households are paying more than 30% of their income in housing. Over 50% of Roseburg renters are paying 30% or more of their income on rent, and 30% are paying more than 50%. Folks, these Douglas County residents are living on the edge of homelessness. They can't afford medical bills. My next slide speaks more to county demographics. Relative to urban areas, we're a poor county. Our average income is less. Our population is older. We have more children and families living in poverty, and our health rankings, as measured by chronic diseases and unhealthy habits, is one of the lowest in Oregon. These are good people. They're our neighbors, and they deserve good medical care. Access to primary care is critical, but at the same time, the need for primary care is increasing. The next slide shows we have a shortage. We have a shortage of doctors in rural areas. Our patient to physician ratio is 50% lower than the state average. Look at the health insurance categories for Douglas County and also Evergreen Family Medicine's experience. At Evergreen, 25% of our population is Oregon Health Plan. 40% is Medicare. So about 65% of the time, our principal payer is the government. Now, that's not bad. I'm really grateful the government resources are there, but it's a big footprint. And it's a powerful force that influences our practice. What requirements will be next? None of these things that I've changed about can I change. I can only evolve. I can only change what I do, what we as an organization does as we respond to the reality that we face. What has changed most dramatically in my 40 years is not the technology or any of these forces. Rather, it's an awareness that rather than just waiting for the patient to call, make an appointment, knock on my door, and ask for help, our medical group needs to consider the patient not in front of us, needs to consider the unarticulated needs from the most vulnerable, and to promote a healthier community to live in order to improve wellness. There are so many measures imposed on our medical group by the government or private insurance. We'll meet those standards. We will. But we can never allow those metrics to become the goal. The little things can't become the main thing. I'm convinced that the most critical factor for good medical care is timely access to a competent provider that listens. If we do this, and if that provider is supported by a comprehensive care team, then we will meet people's needs. And that's the metric Evergreen needs to care about. On my next slide, I look at the key attributes that I think a primary care system needs in 2021. I'll let you look just for a few seconds at those 4 characteristics. I'm going to talk just for a short while on each one and expound to explain why they're so key and why they're so important and frankly what they mean. My next slide begins with accessibility. Simple availability is a huge issue in this community. Patients cannot get into the providers, sometimes even for routine refills or care, let alone when they're sick. Access has to mean more than a message saying call 911 or go to the ER if this is an emergency. There's no higher metric than simply being available. But it's also important that we rethink what access means. I'm going to show you why that is and how critical it is to organize the work to have a system of care. The next slide shows tools of access. For each of the criteria that I've mentioned that are important, you're going to see tools that we bring to work on this. But I want you to just look at this slide for a bit because all of this is access. Now, at the upper left, direct patient encounters, that's what most people think of access. You come in and you see the doctor. For Evergreen Family Medicine, we had about 115,000 of those direct patient encounters in 2019. I want you to look just under that and you see something labeled buckets. This is the place in our electronic medical record. It includes every patient question or contact. It could be the need for what were the results of my clinical studies, what do I do now, medication concerns, referrals, just a large assortment of patient needs. But they have this one thing in common. One of our staff members must touch it. Over 30,000 a week. Now, this is in addition to the thousands of phone calls, the hundreds of forms, the scheduling needs, and all the other connections. This is all access. Because if we don't do this well, oftentimes folks do end up in the emergency department or in urgent care for a need that really should have been addressed at a much lower, convenient, and less expensive level. Now, these numbers, when you look at the ones on the left and also the ones on the right, explain why the next key characteristic is efficiency. Because 30,000 buckets is 30,000 opportunities to make a mistake. Efficiency means reducing variation, eliminating process barriers, eliminating time wasting and dangerous workaround. It requires that we do process mapping, making the right thing to do the easy thing to do. Instead of 30 people doing a task, have one person do it 30 times. Process mapping requires that we understand what everybody else is doing. And we constantly reevaluate every one of our process in a PDSA, that stands for Plan, Do, Study, Act, Cycle. We need to prove efficiency. And the process eventually chosen has to be the most simple and the most predictable one possible. This requires an evolution on our part to thinking on a systematic and a population level. Our next slide shows the tools we use for efficiency. Our patient-centered home committee works on processes and systems to maximize efficiency, to develop outreach programs, to remove barriers. Every area of our practice is represented on that committee, from providers to receptionists. Everybody has a representation there because everything has to work together. Our protocol committee works under the patient-centered home to work out every detail. We train, and then we expect people to work at the top of their license. Our quality improvement committee tracks outcomes, everything we do, so that we can identify problems and constantly improve our performance. We work to organize our clinical teams. We've clearly identified who they are and everybody's role, so the patient is never left stranded if a provider is not available or maybe overbooked. Within our population health, every Evergreen patient is risk stratified into levels based on their health status. The intention is to allow us to focus our resources where they're most needed. Who needs that extra help or attention? We develop processes. An example would be scribes that allow our providers to really engage with our patients rather than being distracted by clerical duties. There's always a next thing to do. This is so different from when I started. It requires a different way of thinking, and some employees and frankly some providers simply can't adapt to this. And if we can't use them if they can't. Our next key is to provide truly comprehensive care within our patient-centered home. Comprehensive means care over the entire life spectrum, birth to death. It means the whole person, physical, emotional, and spiritual needs. It's thinking of the people that are supporting and living with the patient. It's engaging our community to wellness. On our next slide, we list some of the tools to do that. I really wish I had time to speak to each of these. Evergreen staff has invested so much time and energy to make these real. Chronic care nursing engages especially elderly folks that oftentimes are overwhelmed with multiple conditions, multiple meds, multiple doctors. These people are assigned to one nurse for all their needs, one nurse, one number to call, one nurse to check on them, to make sure that they're taking their medications correctly, to interface with their provider, to answer questions. And it can be expensive, but it's more expensive if we don't keep them out of the hospital and emergency department. We have so many support groups. These have suffered a bit during COVID, but we're getting them going again. We have a chronic pain support group, a support group for diabetes, for dementia, more for the family and spouse of the individual with dementia. A lot of people probably don't know that we have patient advisory committees. And this is to provide input from the patient side that can see things that we may not. That's been very, very helpful, by the way. All of these are critical tools if we are to provide the critical comprehensive care we intended within the patient-centered home. Our next and our last key characteristic is affordability. The best care in the world is irrelevant if people can't afford it. At Evergreen Family Medicine, we offer a sliding scale based on income. We accept all patients, all insurances or lack of it. We employ resource coordinators to connect patients with the help that they qualify for. This year, we started a pilot healthcare insurance plan focused on our own employees. And this is where the employer, which in this case is us, pays a monthly stipend, and all primary care is without charge to those employees. This can actually provide value to the employers who are self-insured because we're absolutely convinced we can reduce the total insurance cost if we provide good primary care. The only thing that will disqualify you from care at Evergreen Family Medicine is your behavior. Let me tell you a story. I want to illustrate why this is so important, this issue of affordability, and then I'm going to quit. So that's next. A young woman struggled with alcoholism. The last time her family physician had seen her, she was headed to rehab. She had lost custody of her son. She was broken. A few years ago, this same physician saw this lady's name on their schedule. The young lady had made the appointment mainly to share with her physician how far she had come. She was in recovery. She was working at a nonprofit. She had custody of her son again. She was independent. She was able to pay her bills. She had signed up for the Affordable Care Act for insurance, and that was the only reason she could afford to see her doctor. She had her self-respect back. As she was leaving, she said, "Oh, I have this small breast bump. It's probably okay." It wasn't okay. The doctor explained the need for a diagnostic mammogram. There was this poignant silence, and the patient asked, "Does my insurance pay for that?" She didn't ask if she was going to live. She didn't ask for any details of the prognosis. Does my insurance pay for that? Well, no, it doesn't. You see, the Affordable Care Act insurance pays for preventative care such as the visit on hand, but now this had become problem focused and a huge deductible applied to that. How much is it, she asked. Well, I don't know, the provider said, I'll find out. Well, it's around $600. And of course, that was just a start down a difficult and expensive road. The young lady began to cry, broken again. Broken not because of any failings of her own making, but due to a system that had failed her. Nobody's fault. I wonder if you recognize this person. She's our neighbor. We make our friends, we make our enemies, but God makes our next door neighbor. At Evergreen, I know that we are not going to fix the state. We're not going to fix the national problems in our healthcare system. But we can do and we must do what is possible to take care of our own community. Government won't do this for us. It's not that they don't see the solution. They don't see the problem. We do. We will not pretend it's not there. Brian, that's my presentation, and I thank you very much for helping with that. I'd be happy to look at any questions that have come in.
Yeah, thank you, Dr. Tim. The questions that we have start with, why has healthcare become so expensive?
Well, that's a great question. Why is healthcare so expensive? It's a question I think about a lot. I wish I could change it. Let me say this, good primary care is expensive. And yet when it's done well, it actually creates a cost saving for the entire system. Primary care provides about 75 to 80% of the total patient visits, but it accounts for only 5% of the total medical cost. I'm going to say that again because that's staggering. Primary care provides for about 75 to 80% of the total visits, but accounts for only 5% of the total medical cost. With the concept now of the patient-centered primary care home, and we take that concept very much to heart, the spectrum of services expected from the family medicine clinic is drastically different. With each added service, each added metric or mandate by the government or insurance, our cost increase. Evergreen, I mentioned I had 2 employees when I started. Evergreen now has over 250 employees. In 2020, our total expenses was nearly $30 million. For a kid from Myrtle Creek, that's staggering. New physicians come out of medical school, oftentimes $300,000, $400,000 in debt. It's not comfortable for me to really think of medicine as a business. But I will tell you, if we don't treat it as that, if we don't operate within financial realities, our best motivations are worthless.
Yeah. Also, we should let people know that if they do have a question, that they can ask it right now live, as the program is live. Now later, live answers to questions are a little more difficult. But if you are watching and you do have a question right now, is a fantastic time to do that. Another question for you, Dr. Tim, is it hard to recruit good new doctors to rural Douglas County?
Well, it can be. It can be. And yet Evergreen has added 40 providers since 2016. And what we've learned to do is fish in the right pond, Brian. We have learned to target family medicine residencies that specialize in training physicians that want to work in rural areas, places like Idaho, Montana, West Virginia, Oklahoma, Texas. We do that, first of all, because people that choose those type of training sites do so because they want to work in a rural area. I love Douglas County. I absolutely love, but not everybody wants to live here for some crazy reason. Some people prefer to live in Portland. Secondly, these doctors that are trained in these rural residencies are trained to do more than an individual who's going to practice primary care in an urban setting. These doctors want to do procedures. They want to see patients in the hospital. They want to deliver babies. They want to practice old school family medicine. It really warms my heart to meet these people. It's what I signed up for when I went into medicine, and it's good to see that that hasn't died.
We have another question. I've heard many of my friends who have Medicare complain they have difficulty finding a doctor. Why is that?
Well, they probably have. It's sad, but it's true that of all the insurances we deal with, Medicare pays most poorly. Don't get mad at me. I'm on Medicare. I'm old. But at the same time, the patients, like myself, are more complex and we require more services. So the decision to limit the number of Medicare patients in a practice is common and is not personal, is not intended to be offensive. It's based on realistic business awareness. Now, I will say that Evergreen does not. We do not limit the number of our Medicare patients. And that's probably why we have about 40% of our practice who are covered. But in doing that, we better take to heart that we need to provide that care efficiently and as effectively and as least expensively as possible. And that includes, by the way, a good use of our chronic care nursing program to manage people, to keep them out of the hospital. For a lot of people, they would do much better. There are certain Medicare Advantage plans that allow us to do a very comprehensive physical every year. And with that, we can really organize a care plan that, again, saves the whole system money because we've connected them with the resources that they need and really understand their processes well.
We have a couple other questions as well, but a follow-up to that actually might be somebody saying that whether it's Medicare or not, some people do struggle finding a primary care provider as well, whether they are old enough to qualify for Medicare or not.
You're absolutely right. And that's well said, Brian. The other thing, frankly, that is increasing as our, if you will, payers is no pay or self-pay. And that's just partly due to COVID. I know in the impact of the economy and our commitments, we're going to take care of those people. We absolutely will. But we have been growing rapidly. We have a clinic in Myrtle Creek. We have 2 clinics now in Roseburg. We're planning to extend to Sutherland. We're continuing to recruit. And we're recruiting for providers with the heart that I'm speaking of and providers that really want to work within a team. Because I'm increasingly or totally convinced that this 2021 model is going to be team-based. This single inefficient model of one at a time, and there's a place for that, coming in and visit is just not sufficiently efficient. As we get into other models like direct care, for example, that I spoke of, where there's a monthly stipend or premium and then everything's taken care of, there's a lot of care, a lot of technology available now that we can provide care at home, including with our telehealth, not just audio visual, talking with them like we're doing now, but actually provide an exam, listen to heart and lungs, listen to look in their ears, nose and throat, do a good skin exam. We can do EKGs, ultrasounds, all from a distance. And there's a lot of things we can do in group visits, and we're going to have to really think how we can really efficiently provide people's care in the most cost-effective manner. I'm absolutely convinced there's enough medicine within the medical system. Too much of it never gets to the point of care.
Well, our next question is about telemedicine, actually. How can you do the examination and tests required when you use telemedicine to treat patients at school or in the nursing home?
That's a great question. And I will tell you, Douglas County has 46 schools. We have a school-based clinic at Roseburg High School and otherwise none. Evergreen is absolutely committed to putting a school-based telehealth program within every single school in Douglas County, and that's from Glendale to Elkton. We're going to get there, but we're going to have to be that very efficiently, because I can't put a provider in each one of those, but I can put a nurse within a district. And we have a suitcase very much like the military uses for distant care that she will take from location to location, where we can do basically the eardrum or the throat fills up my computer screen and I can see it better than I can in person. We can listen to heart and lungs. We have electronic stethoscopes. I mentioned the ability to do EKGs and ultrasounds. And we can also do point of care testing there, urine test, COVID test, strep test, mono test, on and on. And that's really critical because a lot of these kids have difficulty with transport, getting into where the care is. A lot of the parents are not able to take time off work. What happened in the nursing home is when the patients came out to see us, they had to go into quarantine for 2 weeks when they went back. That's just cruel. That's horrible. Breaks my heart to think of that. So by sending a nurse out there, and it requires that we do send a nurse on location to hook all these people up, we're able to provide equal exams and equal care to what we would have in person without having to transport the patient. And for example, in the nursing home, what we have the advantage of then is the nurses there, the nurse that knows them. Previously, they would come to my office, and oftentimes the patient doesn't know why the appointment was made or why they're there. They just want to make sure they get back in time for lunch. And the driver that brought him went out for a smoke somewhere, and he doesn't know about him anyway. And so it's a little bit of a wasted visit. Now, our nurse that goes out there communicates before we ever connect with the patient with the nurses there. They go over all the meds and make sure that they're all correct. We ask about any problems or questions the person's having. And then we connect with our doctor and we go through the whole thing. And then our nurse reviews all that with the nurses there. And so it just cuts down on so much misunderstanding, but it also, the patients aren't carted around for very little and sometimes even diminishing returns in value.
Okay, one more question for this episode today, the inaugural Evergreen Talks Facebook Live, also on YouTube Live, by the way. Last question for you, Dr. Tim. What is chronic care nursing?
I've alluded to this several times. It's very, very important to me. It's because I totally understand the value. And it's an example of something that costs money that saves money. A lot of our seniors, and I'm on Medicare, so don't throw rocks at me, have reached a place where their health care is complex. Sometimes they have transportation problems. Sometimes they have understanding problems. And they may have diabetes, congestive heart failure, COPD. They may see multiple specialists, and they really have difficulty remembering or keeping track of their treatment plan and following it. And that costs all of us, because a lot of times they do go to the emergency department or admitted for things we could have avoided if we really would have stayed on top of things. Nobody is well served by that. So we assign a nurse to them. And this nurse has a panel, just like a physician has a panel. Now, each of those patients also have a physician, of course, but this nurse is an intercessory between the patient and the provider. Now, they can still come in and see the provider, but in between, she is the one calling to make sure they're following their plan, they're checking their blood sugars, maybe they're weighing daily if they have congestive heart failure, whatever it is. And a lot of times questions come up. Maybe they're having trouble breathing, and we can talk through that. Sometimes there's wound care issues, and we even send nurses out there so that they don't need to come in. But sometimes just frankly an encouragement call. So each of these nurses has a panel maybe of 200 people or so. And this nurse then knows how the system works. They can have direct access to their provider much easier than a patient can, and then can get back to the patient with answers that they can follow and understand. The cost for this is covered by Medicare, because it absolutely saves money. As a matter of fact, Medicare is always pushing us to do this more. And when I said we did the population health and the risk scoring, there's a certain category of patients that we know that this is the ones that really need these resources. It's well worth it. We're not going to bug the people that are doing fine and don't need that. Unfortunately, a lot of the times the very people that need it say, no, I'm fine. And then they end up in the emergency room time after time. If the person does have Medicare, but does not have a supplement, then the cost is $15 a month. That's their copay. But at one trip to the emergency department can be thousands of dollars. So this is really a critical component of our patient-centered home concept.
Well, that's the end of our Q&A session for today, and I think the end of our first episode here, Dr. Tim.
Brian, thank you. I enjoyed it. Each month we're going to do this, and I hope people will think about joining us. I'm going to say again, if there's specifically topics they'd like to speak to, or like us to speak to, we will try to do that. There's so much we can engage in. Previously, we've talked about things like end-of-life decision-making, controversies in vaccinations, spirituality in medicine, what goes behind the scenes that you wonder about in a doctor's office. This is our attempt for a community forum, and sometimes I don't know what's important to you, and so I would love to know that. And if there's enough people, enough interest, we'll definitely arrange a talk on that basis. But thanks everybody for their time.
Yeah. All right. Well, Evergreen Talks will come back again, so keep a close eye on the Evergreen Family Medicine Facebook page, and of course you can follow all the things that are happening with Evergreen Family Medicine at evergreenfamilymedicine.com, and as you are doing now, follow us on Facebook and YouTube, but also Twitter and Instagram as well. So Dr. Tim, I hope you have a good day and a nice weekend coming up.
Thanks, Brian. Thank you very much.
We'll talk to everybody again.